Physical accessibility. This refers to the physical distance as well as topography and terrain which individuals must travel in order to participate in the treatment. Acceptability. This refers to the cultural, social, and psychological conditions, which includes ethnicity, practices, culture, beliefs, religion, and language. This will be measured using a technique patterned off an acceptability study for treatment of malaria. Alternative treatments. The presence of other alternative treatments for schistosomiasis, such as herbal medicine, traditional healers, and the like, can be a factor. This will be measured by including a question on the survey asking for the presence of alternative treatments. Economic and financial status. This refers to the affordability of the treatment, not limited to the cost of the service alone. This also refers to the number of labor hours lost to participation in treatment with the corresponding monetary value, quantified as the opportunity cost of time. Social support network system. The presence of social network support systems and membership in these groups can also be a factor. This also refers to the social network, socio-demographic characteristics, and lifestyle of a participant. Government intervention. Under law, LGUs or local government units are encouraged to follow certain guidelines in addressing schistosomiasis, and whether they comply with the rules or not can be another point of exploration.
Need factors are those that directly influence the utilization or acquisition of services, under which we have identified three specific ones. Patient perceived severity will be patterned with the health belief model, which aims to determine the level of illness to which respondents consider severe enough to prompt the need for treatment or intervention. Symptom-derived severity will be assessed through a service to recognize symptoms, which signifies that the disease has gone to a certain level of severity enough to seek treatment. Lastly, the total number of sick days will be measured through a survey as patterned after the healthy days measures to determine the number of days the disease has hindered them from performing their daily tasks. As previously mentioned, the study will be conducted in Western Samar, which is the sixth of the 24 schistosomiasis endemic provinces in the Philippines. People in Samar are highly prone to diseases like schistosomiasis since they have direct contact to fields in infected waters. Particularly, the group will be choosing an endemic barangay in Western Samar where there was mediocre mass participation in their previous mass treatment activity. Only one barangay will be the area of study since it will be more accessible and more practical to do so considering that the study analysis will be at the individual level.
There are three aspects to the approach of the survey process: before, during, and after. Pre-survey. Survey questionnaire drafted parallel to objectives. The survey questionnaire was crafted parallel to our objective. As such, all data called for by the survey questionnaire are seen as relevant, applicable, and important for the said study and the people. Informed consent. Considering that certain information will be collected, participants will be informed that all information will be kept confidential with some exemptions. These include information in the public domain, administrative purposes, and medical records if anonymity can be maintained. Face-to-face or personal. The survey research method should be able to draw out the desired information from survey respondents most effectively and efficiently. And through a personal face-to-face survey, one can gain trust and relay his message easily and clearly. Standardized survey. Problems of biases can be a concern. In order to address these concerns, the survey will be standardized for all participants to ensure consistency and regularity in conducting the survey. Study of cultural background. Samar is different from Manila in terms of culture and ways of living. So for better socialization and appropriate approaches, an informed background of the area will be conducted. This includes the translation of the survey into their native tongue for ease in understanding and communication with the participants. Survey proper. The plans and purposes of the study will be discussed so the participant is aware of who we are, what we're going to do, and why we're there. As such, an informed consent will be acquired. No respondent will be forced to participate in the study survey if he or she does not desire to do so. Furthermore, confidentiality will be ensured for all information that will be disclosed. This will be done in a light, casual conversation to establish a friendly, sincere, and honest atmosphere. Post-survey. No information will be disclosed to any unofficially involved third party unless of absolute necessity. It will only be disclosed to officially involved parties, specifically those who are perceived to be directly or potentially affected by any changes brought about by the study. There will also be transparency in data handling, such as linking of personal information and survey responses to ensure utmost intelligence and guidance in data management.
An endemic barangay with mediocre mass participation is desired so as to have fairly equal number of subjects in the study to be conducted. This is because the chosen study design is a case control study. In a case control study, one group among whom a problem is present, or the cases, is compared with another group where the problem is absent, or the controls, to find out what factors have contributed to the problem. Here, an association or relation between an exposure and an outcome may be generated. Moreover, case control study is used for rare outcomes and for multiple factors for a single outcome. Given that the primary objective of this study is to determine the effects of health-seeking behavior on the participation of an individual in schistosomiasis mass treatment, the exposure factor will be the individual's health-seeking behavior, while the outcome will be the participation or non-participation in the mass treatment. The selection of subjects is based on the presence of outcome on an individual and not on exposure status. Thus, the cases for this study are the barangay residents who participated in mass treatment, while the controls are those who did not. In selecting the cases for the study, random stratified sampling will be done from the list of mass treatment participants in the barangay using participation as the strata. This list will be provided for by the Provincial Health Office of Samar. On the other hand, controls will be selected through random selection of the neighbors of the selected cases. The first neighbor to the right or to the left of an identified case will be selected as control. The direction of the selection will be done randomly through a toss coin. However, if that neighbor is also a mass treatment participant, the succeeding house or houses to the right or to the left will be selected until a control has been found.
Next, for the sample size computation, EpiInfo was used, a software application that has a feature on computing sample size given certain variables. As seen on this table, the sample size of the study can be computed in two ways. The first three variables given are confidence interval of 95%, power of 80%, and odds ratio of 2. Using gender as the factor in computing the frequency of exposure in the control group, or the percentage of males of those who did not participate in mass treatment, the value was estimated to be 50.8%, resulting to a sample size of 149, that is, 149 cases and 149 controls. On the other hand, using age as the factor, the frequency of exposure of those 16 to 40 years old who did not participate in mass treatment, the value was estimated to be 67.37%, resulting to a sample size of 144. That is, 144 for cases and 144 for controls. The group chose the higher sample size of 149. Lastly, for the study variables, the dependent variable is the outcome or participation in mass treatment, while the independent variables are the exposure factors or the predisposing, enabling, and need factors previously explained. For each variable, the indicator, scale of measurement, descriptive statistics, and bivariate statistical test to be used were determined and were used to formulate the survey questions. This is the thesis group's Gantt chart showing our detailed work plan for the next couple of months.
All data gathered and results produced will be descriptive and informative, providing further information regarding the ongoing mass treatment in the consumer's health-seeking behavior perspective. These data generated will then be used to help improve the current mass treatment by providing a more appropriate, effective, and enhanced means and forms of services based on the consumer's health-seeking behavior. Lastly, this can start a more holistic approach in the improvement of the mass treatment in order to maximize efficiency and effectiveness of mass treatment for all stakeholders, may they be directly or potentially influenced or affected by it.